Hi everyone, welcome to week 2. I hope week 1 was fun for everyone and you got a lot of clinical experiences. Dr. Mileham sent out your floor assignments for this week. Please seek those opportunities. Being passive for APU clinical is just not going to work. So again, just reinforcing, you need to seek those clinical opportunities. You need to ask, you need to be engaged, you need to be inquisitive. So we're going to discuss neurological disorders this week, and hopefully this will help you kind of connect what you're seeing in clinical practice with your didactic class. By now in level 4, you should know signs of neurological changes that you've seen throughout clinical, whether it was in long-term care, semester 2, semester 3, and now as you are starting your semester 4. So off the bat, level of consciousness. So is it a new onset of confusion, agitation, or restlessness? And I think the most important thing of all of this is knowing your patient's baseline. What were they at a neurological baseline before they got admitted? Or what were they like at the start of the shift versus the end of the shift? Are they drowsy, lethargic, or is it difficult to arouse your patient? Are they having decreased responsiveness or unresponsiveness? And was there a sudden change in orientation that would include person, place, time, and situation? Pupil changes. Pupils that are unequal in size, pupils that may be sluggish or non-reactive to light, is that at a baseline or not? Are there fixed and dilated pupils, which is an ominous finding? So making sure you understand what that means, and when you're grading the pupil size as well, what that means. If we wanted to talk about motor and sensory changes, things such as weakness, numbness, or paralysis, is it both sides of the body? Is it one side of the body? Is it a residual from a past stroke or a TIA? Do they have essential tremors, or do they have any type of involuntary movements that you see? Any loss of coordination or difficulty walking? Are they also complaining or have any nuanced sense of jerking activity or seizure-like activity? When it comes to speech and communication, there are a lot of things that you can notice right away with your patient. Is their speech slurred? Are they having difficulty finding words, which is also known as aphasia? Or are they suddenly unable to speak or understand what you're saying to them? Blurred or double vision, loss of field vision, sudden blindness in one or both eyes. Maybe they've had loss of vision because of a retinal detachment, or maybe they've had a tumor. Also, something important with vital signs and autonomic changes. This is something you really want to focus on for this semester and this portion of your didactic. Learning about Cushing's triad, which is actually a late sign of increased intracranial pressure, also known as ICP. So that'll include that widened pulse pressure, bradycardia, or any irregular respirations, sudden hypertension or hypotension, and also a change in respiratory patterns such as chain Stokes or agonal breathing. So something I always like to discuss with students in clinical is the Monroe-Kelly hypothesis. I think it's extremely important that you understand this and kind of take this with you in whatever field of nursing you decide to go into. So the brain is made up of 100% of components. 80% is brain tissue, 10% is blood, and the other 10 is cerebrospinal fluid. So the total volume inside the skull must remain intact, and it must be constant. It must constantly be at 100%. So if the volume of one component increases, then the volume of another component must decrease in order to maintain that normal ICP, which, as we know, is between 5 and 15. So this whole hypothesis just explains that the skull is a fixed space containing these components. The others must decrease to maintain normal ICP. So in acute care nursing, this is critical because signs of altered level of consciousness, pupil changes, as we discussed on the last slide, or Cushing's triad can indicate that the patient's compensation is failing and dangerous intracranial hypertension is developing. So this is very, very important. As a last semester nursing student preparing to graduate, it's important to understand compensatory mechanisms because they explain how the body maintains stability under any type of stress. So, recognizing these responses like increased heart rate and shock, or cerebral blood flow shifts in raised intracranial pressure, it'll help you detect when patients are just kind of coping versus when they're actually decompensating, which is really important for you to know. This knowledge allows you to anticipate deterioration, intervene early, and communicate critical changes effectively to the healthcare team and providers, skills that are essential as you transition from student to practicing nurse. So I've listed here some relevance to your clinical for this week. So, when you're looking to see, maybe I'll pick a patient that has a neurological deficit or neurological disease, it might make it easier, for you to understand, how that's relevant and how you can bring your clinical practice into the didactic. So, general concepts, super important for you to understand for the inpatient care setting because they give you kind of a framework for recognizing early neurological changes before they become life-threatening. So by knowing the basics like level of consciousness, pupil response, motor function, and compensatory mechanisms like we discussed earlier, you'll be able to quickly distinguish normal from abnormal. So it's always super important to know abnormal, and it's also really important to know the normal. So this will help you quickly pick up subtle warning signs of stroke, seizure, or increased intracranial pressure. You'll be able to communicate again with the care team, and you'll be able to prioritize timely interventions. So in short, understanding these concepts allows you to connect symptoms to underlying physiology and provide safer, more proactive care. For the patient who has had trauma or traumatic brain injury, you'll want to focus on maintaining airway and stabilizing the cervical spine. Signs of ICP, again, Cushing's triad. I think that's like the third or fourth time I've said it, so hold on to that thought, okay? Level of consciousness changes and pupillary changes, dilated, pinpoint, constricted. And you'll always assess levels of consciousness first in neuro patients and always know their baseline. Again, baseline, super important. For brain tumors, focusing on recognizing level of consciousness changes, focus neuro assessments. Tumors, they can increase ICP, they can cause seizures. Personality changes can be seen and they may also cause deficits, residual, or pain. And then abscess, you want to think fever, focal deficits, and increase ICP. So always finding the source. So for cranial surgery, I know I've said this again, you'll want to look at increased ICP or ICP, Monroe-Kelly hypothesis. You want to know and have a good foundation for a neurological assessment. Also include your Glasgow Coma scale for level of consciousness. That's really important. Post-operative risk and complications, so bleeding, hematoma, sudden neural decline, cerebral edema, infection, seizures, cerebral spinal leak, clear drainage from the nose or ears. Remember halo sign, that's a heavily tested item. Knowing how to care for patients with meningitis versus encephalitis is critical because, as we know, both conditions involve the central nervous system, but the cause, presentation, and nursing priorities differ. So if you were to mismanage either, it can result in permanent neuro damage or death of your patient. So for meningitis, you'll see inflammation of the meninges. It's often bacterial, but it can be viral. It progresses fast, and there is a high mortality rate if it goes untreated. It does also require isolation. This is a big NCLEX test tip. They love testing on precautions and safety as well. So for encephalitis, you'll want to think of inflammation of the brain tissue itself, which is commonly caused by viral infections. For example, HSV. It's more likely to cause profound neural changes, seizures, and long-term deficits. So it will be managed with antiviral medication, VIR, seizure precautions, and supportive neuro care. So make sure you have a good understanding of the difference and ensures that you anticipate complications, protect the patient and staff, and intervene quickly. Some hallmark signs of meningitis: neutral rigidity, positive Kernig's and Brodzinski sign, and photophobia. The NCLEX loves to test these, so these are things that you need to know. Encephalitis, the hallmark signs are profound altered mental status, confusion, personality changes, and seizures. So your priority For suspected bacterial meningitis, you'll initiate droplet precautions and give IV antibiotics immediately, and don't delay for a lumbar puncture. Safety, you're always going to put meningitis and encephalitis patients on seizure precautions, and then you'll also watch for complications such as SIADH and meningitis and long-term cognitive and motor deficits in encephalitis. I'm going to keep it real brief for strokes. So you have ischemic and hemorrhagic, and knowing the difference between those is extremely important because with one you can give TPA and with the other you cannot. Also, you want to remember FAST, face, arm, speech, and time. So time is brain. Early recognition and rapid response are critical, so sudden changes in speech, vision, strength, or level of consciousness should be treated as a medical emergency until ruled out. Nurses must activate stroke protocols immediately to preserve brain tissue. And second, nursing priorities focus on safety and monitoring, maintaining airway, preventing aspiration, monitor neural status closely, and protecting the affected side. So if you have a stroke on the left, you'll more than likely see symptoms on the right, and if you have a stroke on the right, you're more than likely to see symptoms on the left. Headaches. They're super common, but nurses need to know the key types. First is tension, like headaches are the most common. They're dull, pressure-like, pain around the forehead, temples, or even the back of the neck, often stress-related and relieved with rest, NSAIDs, or relaxation techniques. Second, we have migraine headaches, usually unilateral, throbbing in nature, and may come with nausea, photophobia, or an aura. Triggers can include certain foods, stress, and hormonal changes. You'll treat those typically with triptans, and you'll want to avoid triggers in a quiet, dark environment. Cluster headaches are severe, unilateral, stabbing, usually pain is around the eye, often occurring in cycles. Patients may have tearing, nasal congestion, or restlessness. High flow oxygen and specific meds like sumatriptan can relieve them. So if a patient reports the worst headache of their life, you need to think of a subarachnoid hemorrhage until proven otherwise. For migraines, priority teaching is identifying and avoiding triggers. For cluster headaches, NCLEX also likes to highlight oxygen therapy as a key intervention, so just make sure that you remember those. So briefly, we'll talk about epidural hematomas. These are bleeding that occurs between the dura mater and the skull, usually caused by either a head injury with an arterial bleed, which is a fast bleed, and it is a true neurosurgical emergency. So the classic presentation, you'll have brief loss of consciousness, followed by a lucid interval, and then rapid neurological deterioration as bleeding increases the ICP. Some assessment findings you may see would be headache, nausea, vomiting, ipsilateral pupil dilation, a blown pupil, contralateral weakness, decreased level of consciousness, and signs of increased ICP. The treatment will be immediate surgical evacuation, a craniotomy, or burrs holes to relieve pressure. So some tips for NCLEX: if you see loss of consciousness, lucid interval, rapid decline, think epidural hematoma. Priority nursing action: prepare for emergency surgery and perform frequent neuro checks. And do not delay. This condition can be fatal within hours for our patients. Seizure disorders, we classify those as abnormal and controlled electrical discharges that go off in the brain that can cause sudden changes in movement, sensation, behavior, or awareness. So you have three types: generalized, which includes tonic-clonic, and grand mal, which is loss of consciousness, stiffening and jerking, and a post-ictal confusion. Absence, which is brief staring spells, often common in children. And then focal partial, which is localized twitching or sensory changes that may or may not impair awareness. So nursing priorities, as you know, maintaining airway and safety, never restraining movements, and never placing objects in the patient's mouth, noting the time, type, and characteristic of seizure activities. In post-ictal phase, assessing airway, reorienting the patient, allowing rest, and document findings. Spinal cord injuries is damage to the spinal cord, as you know, that results in either loss of motor, sensory, or autonomic function below the level of injury. So the higher up on the spinal cord you go, the worse your symptoms are going to be, okay? So severe depends on whether the injury is complete or incomplete. So common complications, you can go into neurogenic shock, which is hypotension, bradycardia, warm, dry skin due to loss of sympathetic tone. You can also have spinal shock, which I talked to you guys about last semester. So temporary flaccid paralysis and loss of reflexes below the injury. And then autonomic dysreflexia. If there's anything I want you guys to remember from this section is understanding that T6 is your important area. So this is when the injury is T6 and above. You have sudden hypertension, pounding headache, diaphoresis, bradycardia triggered by bladder or bowel irritation. And this is a life-threatening emergency, so making sure that we are doing eyes and nose, we're frequently doing our neuro checks and assessing our patient. So in suspected spinal cord injuries, you'll want to immobilize the spine first. For autonomic dysreflexia, you'll want to elevate the head of the bed, check for bladder or bowel distension, remove noxious stimuli, and then notify the provider. And then cervical spinal cord injury is the highest risk for respiratory failure, so you want to monitor ABCs closely. Guillain-Barré syndrome, also known as GBS, is an acute autoimmune disorder. So the body's immune system attacks the peripheral nerves, okay? So it can happen after a viral or a respiratory infection. I actually have a nursing colleague who got it after eating clams, and then she woke up a few days later and could not walk. And also, it's a common question that we ask when we are vaccinating patients, because vaccines can trigger Guillain-Barré syndrome in someone who has had a history of having a flare of it. So it's symmetrical weakness and loss of reflexes, and it begins in the lower extremities. So when you're talking about all these neural disorders and you're like, oh my goodness, there's so much to remember. How am I going to remember this? Remember, some of them start at the top and go to the bottom, and some start at the bottom and go to the top, okay? So you'll have possible numbness, tingling, and pain, and this can progress to respiratory muscle paralysis and risk for respiratory failure. So when you're learning about these different neurological disorders, especially the next couple that we're going to go over for this pre-conference, make sure you also understand the use of what a bulbar muscle does. So that's B-U-L-B-A-R muscle, and that will help you keep everything very organized. If you want to make a chart for this, that's what I did when I was in nursing school. I found that to be very helpful. So I could kind of compare and contrast, because a lot of you always say, well, there's just so many, there's just so much information. How do I organize it? That is how I organize mine, understanding which ones affect the bulbar muscles, which one starts toes to nose, and which one goes nose to toes. So the priority here would be respiratory failure, always assessing breathing first, and then also watching for autonomic instability. So you'll see maybe possibly sudden swings in blood pressure and heart rate. So typical treatment for this would be IVIG, also known as IV immunoglobulin, or plasmapheresis to reduce the autoimmune attack that's circulating. And then recovery is possible but may take weeks to months, but early intervention improves outcomes. For those who have had me before, you will probably hear me in the back of your brain always saying, what's the patho, what's the patho, what's the patho? So myasthenia gravis, it's a chronic autoimmune disorder, yes, but the antibodies destroy acetylcholine receptors, okay, at the neuromuscular junction. So we're going all the way back to like anatomy and physiology, super important. So because acetylcholine plays a huge role in muscle. So muscle weakness that worsens with activity and improves with rest is going to be your key finding with myasthenia gravis. So you'll also have weakness of eye muscles, so ptosis, diplopia, the face and the throat. So they may, again, have issues with those bulbar muscles that I was saying on the last slide. Fatigue that increases with exertion, risk of respiratory compromise if their diaphragm or intercostal muscles have been affected. So there's two emergencies with this I want to make you aware of. Myasthenic crisis, so that means they're under medicated or they have an infection or they're under stress. So you'll see severe weakness and respiratory failure. Or they can have a cholinergic crisis, which is over medication with cholinesterase drugs, which causes muscle twitching, bradycardia, increased secretions, and weakness. So again, priority here, like all the rest, Maintaining airway and breathing. You're going to give medications on a strict schedule, so timing is crucial to maximize their muscle strength. You'll encourage rest periods between activities when needed and educate on avoiding triggers, so stress, infections, certain medications as well, such as aminoglycosides. And what are those medications? That's right, your vancomycins. Okay, next we have multiple sclerosis. So this is a chronic progressive autoimmune disorder. Let me say that again. Chronic progressive autoimmune disorder. So the body attacks the myelin sheath of the CNS. So this will cause slowed or blocked nerve conduction, leading to a wide range of neurological symptoms. So these features fatigue, weakness, visual changes, bladder and bowel dysfunction, cognitive changes, and then the symptoms will often wax and wane with periods of relapse and remission. So that's a key finding as well. Again, promoting mobility and safety is a nursing priority. So fall prevention, assistive devices, managing fatigue with rest periods and activity pacing. That kind of sounded a lot like myasthenia gravis. Teach bladder and bowel programs and encourage fluid and fiber intake, and provide emotional support because multiple sclerosis is lifelong and also unpredictable. So some quick tips for your NCLEX. You'll always want to avoid heat and stress in these types of patients because they can trigger exacerbations. Medications, you use corticosteroids for acute relapses and immunomodulators, so interferons, to slow progression. And MS is a central nervous system demyelinating disease. So you don't want to confuse it with GBS or myasthenia gravis, which affects peripheral nerves or neuromuscular junction. Okay, it is very clear that you can read the slide. So I will leave you with this. Parkinson's disease, progressive neurodegenerative disorder. Let me say that again. Progressive neurodegenerative disorder caused by loss of dopamine in the brain, leading to impaired movement and coordination. So key features, I remembered TRAP as a mnemonic, so I'll share that with you. So T stands for tremor. They'll have that resting pill rolling tremor. R is for rigidity, muscle stiffness, and cogwheel movements. A is akinesia and bradykinesia, slowness of movement and difficulty initiating movement. And P is postural instability, shuffling gait and risk of falls. Your patient can also have a soft monotone voice, a mask-like face appearance, drooling, depression, and dementia in later stages. Again, let me go back to the beginning. Parkinson's disease is progressive neurodegenerative disorder caused by loss of dopamine in the brain. So if you know the function of dopamine in the brain, a lot of these signs and symptoms will make sense to you. So priorities: promote mobility and fall prevention. So they may use assistive devices. They may have a PT or OT consult. You want to make sure that you have a safe environment. They probably will at some point require 24-hour care. You'll encourage small, frequent, high-fiber meals to prevent constipation and aspiration. And you'll also want to be really adherent. They want to be really adherent to their medication management. So levodopa, carbidopa, you'll want to take on an empty stomach if tolerated, and watch for that on and off phenomenon that can occur. I'm sure you're getting sick of hearing my voice by now, but let's talk about ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, which you've probably heard as well. So again, progressive neurodegenerative disorder. So this disorder actually destroys your motor neurons. So this would lead to what? You got it. Muscle weakness, paralysis, and eventually respiratory failure. Importantly, cognition and sensation remain intact. Okay? So it's progressive. It's neurodegenerative disorder. It destroys your motor neurons. And importantly, their cognition and sensation remain intact. So it's important to remember there is no cure, but there is a medication, Riluzole, may slow progression slightly, and you'll always want to address advanced care planning and end-of-life wishes early due to the rapid decline of this disease. Key exam clues would be muscle weakness with intact cognition. So make sure you play this a couple times, okay? Muscle weakness with intact cognition. Okay, hopefully you heard me. Oh, your favorite, all those cranial nerves. And yes, you will still need to know them even after you graduate. So, bulbar muscles matter so much in neurological diseases. They are controlled by the cranial nerves, mostly 9, 10, 11, and 12. In the brainstem, and they're responsible for swallowing, speaking, and protecting the airway. So in neurological diseases, like we have talked about earlier on in this pre-conference, myasthenia gravis, ALS, Guillain-Barré, and brainstem strokes, you all have weakness of the bulbar muscles, which leads to dysphagia, difficulty swallowing, dysarthria, slurred speech, and airway compromise, which will put the patient at increased risk for inability to clear their secretions and puts them also at risk for respiratory failure. So, if a patient has weak bulbar muscles, airway and breathing is the priority, ABCs. Okay, in myasthenia gravis or ALS, also known as Lou Gehrig's disease, bulbar involvement often signals risk for rapid respiratory decline. So you need to be prepared for intubation or an emergency tracheostomy.